Okay, so this lecture is about the adverse transfusion reactions that would occur if we miss something or if we make a clerical mistake and give a person blood that they produce an antibody against an antigen present on the surface of that product that we're giving them. There are several different types of transfusion reactions. The major ones that we're worried about are the immune transfusion reactions. However, we will classify any transfusion reaction based on when it occurs and whether it's immune or non-immune. So in this particular case, you can see that that we can have an immediate transfusion reaction or a delayed transfusion reaction. As a general rule, we're going to say, just because we have to have some kind of time, that if it's less than 24 hours, we would consider that immediate. If it's more than 24 hours, we would consider that delayed. There is some flexibility on that. You know, if something occurs and you don't notice it, because you don't really know when it started. It's when you notice the symptoms. So you might have some flexibility on that. It could be considered immediate if it happened literally in that visit, which might take a few days. And delayed can occur, it can literally occur months later, up to months later. So these kind of things, there has to be some flexibility. But in order to have some kind of cutoff, because you need something, we're going to call it 24 hours for our purposes academically. Okay? And then we further break down whether it's immediate or delayed into whether it's immune or non-immune. So when we're talking about immune, we're saying that there's some antibody-antigen reaction that's occurring here that is actually causing the reaction, as opposed to non-immune, where the patient is having a reaction that's causing some symptoms, but it is not related to an antibody-antigen reaction associated with the red blood cells. So again, we can further break it down. So it basically have four basic types: an immune immediate, a non-immune immediate, or an immune delayed, and a non-immune delayed. But when we give a transfusion, we're going to, what are the signs that tell us that a reaction is occurring? Well, the clinical signs. So we've gone through this before, but just to go through the list again, you can see here on the left, I don't have a laser pen, but on the left you can see the symptoms include fever, chills, or rigor, meaning joint pain, respiratory distress, the patient's having coughing, wheezing, or trouble breathing. Their blood pressure changes, and it can go in either direction, increase or decrease. Any kind of pain, in particular at the transfusion site or in the flank, the back, the lower back side, which is where your kidneys are located. That's usually associated with that. Or otherwise, the next most common is probably chest pain is another one. There can be skin manifestations, so rash or edema, anything like that, which are signs of various types of immune responses. And then, of course, jaundice and hemoglobinuria, those usually don't happen until a little bit later. Nausea, vomiting, abnormal bleeding, oliguria, or anuria. Probably the most consistent sign of an immune response is that fever, any kind of increase in the temperature greater than or equal to 1 degree Celsius. Or if it's greater than 38 degrees Celsius, then we actually have, so if the patient already starts out and they have a fever over 38, then you're looking for that greater than or equal to 1 degree increase. But if their temperature is normal, anything over 38 will be a problem. Now remember, we're giving these transfusions to people who are already sick. So sometimes you can see these symptoms because of other things that the patient can have, for whatever their illness is. So if any of these signs that occur will trigger an investigation into the transfusion. But it doesn't necessarily mean that there is absolutely a transfusion reaction. I mean, after all, you have to have known that, you have to prove that this is actually caused by the transfusion. The key thing is, in the end, it might get stopped but there was no reason to stop it from our perspective, from the blood bank perspective. So when we look at, so you can see the flow chart here. You have transfusion reactions broken down into immediate and delayed, immune and non-immune. So what are the causes? What's in it? You need to know the 4 types of, for example, the immediate immune transfusion reactions. We have hemolysis, febrile, non-hemolytic, allergic, anaphylactic, or trolley. The non-immune causes sepsis, TACO, and pseudohemolytic reactions. And you can see the list is here. You can read through it. We're going to go through each one, though. So the first thing is, what are the main symptoms? You can see this little cartoon here gives you, again, same list. It's the same: fever and chills, the heart rate increases, hypotension, hypertension can occur, pain, as well at any of these sites, and then of course the manifestations in the urine. The key immune trigger for this is generally IgM. The one that we're most afraid of is IgM, and that's because it is so competent at triggering the classical pathway of complement, and that's where we get that intravascular hemolysis that we really don't like. If it's an IgG led immune response, we don't usually get massive hemolysis. IgG doesn't trigger complement as much. It can still interact with all kinds of, other immune modulators, and you'll get all other things occurring. But in general, the one that we're most afraid of really is IgM, because that is so effective at triggering complement. If it is an IgM response, generally you're going to see some intravascular hemolysis. If it is solely an IgG response, we very happily don't see a severe reaction, okay? So remember that not every reaction is severe. Even if it's immediate, it might not be severe, okay? So that's important. As the antibody coats the red cells, the first thing that's going to happen, of course, is it's going to interact with all the different immune modulate the cytokines and all that stuff. But let's say that it is an IgG led response. IgG, one of its best things is that it can trigger opsonization. So it'll activate macrophages, which will then engulf those coated red cells, or the spleen will sequester them. There are other immune responses that can occur. Anaphylaxis is usually triggered by an IgE response, which is completely separate. It is immune, but it's not usually targeted between the red cell antigens. It's usually associated with other things. And then when you trigger those, all of that immune response, of course, the worst case scenario is complement activation, because complement activation will lead to red cell lysis. So that's really our major issue. When the red cells lyse, you end up with all kinds of components entering into the bloodstream that which will trigger even more inflammatory factors into the plasma from the inside of the red cell, from everything else. That'll call in a whole bunch of more immune cells, mast cells, neutrophils, all that kind of stuff. You'll get smooth muscle activation. You'll get serotonin and histamine being released. You get all this kind of changes in the permeability of the vasculature. And unfortunately, it's happening, if it's a very strong response, it can be happening so quickly that you can have a significant loss of the volume in the blood, in the veins, in the vasculature, and it can lead to that lower blood pressure that we talked about, that I mentioned, I'm sorry. And then it can lead to shock, actually, in your patient if it gets low enough. Remember that as all those contents are dumped out into the plasma, the hemoglobin, all that stuff has to be recycled. And so one of our signs that we do have intravascular hemolysis is haptoglobin, which is our normal protein to sweep up all that hemoglobin. As those amounts lower, we have a pretty good sign of how much hemolysis had occurred in the plasma. There are other factors that could be going on. Remember, they're not all IgM led processes. Sometimes it's a IgG led process, which is, I'm not going to say weaker, but it doesn't trigger the same immune responses. Sometimes you can just get literally antigen antibody complexes forming. Unfortunately, those aren't really all that great for you either, because they can obviously build up in places like the kidneys. They can lead to coagulation, which will trigger a fibrinolytic system. In extreme cases, that could lead to DIC. So you see, even with what we would normally consider less severe situations, you can still end up with a severe clinical situation like DIC. Most immune or hemolytic reactions, most times we see an immediate immune response. You will see a reduction in the clotting factors, whether it's due to antigen antibody complexes or some of the other issues that are going on because of that lysis of the red cell. So that's pretty common when you're looking at hemolytic transfusion reactions. It's not uncommon to see that reduction in those clotting factors in the plasma as well, if you look pre and post transfusion. Of course, since you do have coagulation that can be triggered by this process, you can get small clots occurring, especially in the very small vessels, that can lead to tissue ischemia, which is the decreased oxygen supply to the tissues beyond the clot. Unfortunately, that only triggers more clotting. You get a lot of cycles, bad cycle triggers when this kind of stuff happens. And then some of the other things that we're afraid of, really, things like renal failure. And if it's a very severe hemolytic transfusion reaction, that's actually pretty common to go by, to experience at least some amounts of renal failure, and it's usually because of all the factors that have been released into the plasma and all the systems that are being triggered. It does havoc with the small vessels in the kidneys, plays havoc with those small vessels in the kidneys. But that's not necessarily final. So while renal failure, we kind of think of it, failure, we kind of think of it as irreversible. It is possible, if you can react quickly enough, that you can save at least some of the kidney function on the patient, because obviously we really don't want to lose the kidney function. And then, of course, worst case scenario, with everything going on, it is entirely possible, especially if it's an immediate, that shock can occur. When you get enough clots, when you get enough lysis going on, you can get significant loss of volume in the vessels, or a significant blockage of the volume that can lead to shock. So one of the things I just want to remind you of is some of the processes that are occurring here when we have lysis going on. And now these are different processes. You have complement cycle occurring, you have the kinin cycle, and you have the coagulation cycle. And these aren't the cycles, but these are all the things that can be triggered by an immune hemolytic response. You may only trigger one of them. You may trigger all of them. But when you trigger them, I'm giving you what the results are. So in other words, if we look to the left of this, you can see that if you trigger complement, you end up with, if that complement attaches to the red cell, which it would, because that's what the immune response is directed against. If you trigger complement here, then you can see what you're going to affect. What you're going to affect is the red cell, specifically you're going to have an MAC on the red cell surface that'll lead to cell lysis. You can also, by triggering complement, remember that the smaller portion, that's complement, is constantly breaking apart a factor, and you have one factor that's usually involved in assembly of the membrane attack complex, but the other factor is still immunologically active. And those factors, the 5A, those little factors there, they can act as anaphylactoxins, where they cause massive influx of cytotoxins, leading, unfortunately, to anaphylaxis. They can release mast cell granules. Both of these can lead to a drop in blood pressure and eventually shock. It's not necessarily that it's always that way, but it can lead to that. The kinin system, which you see here, this is basically, we're talking about neuroendocrine response to the hemolytic response to the hemolytic reaction. I apologize. Usually one of the things that you see in response to the release of those cytokinins is some kind of neuroendocrine response. In particular, vasoconstriction. That's the major thing. So that requires a neuroendocrine process, and you get vasoconstriction to reduce blood flow to the area. That's normal, but in a hemolytic response, unfortunately, it's triggered throughout the whole system, and you can get decreased blood supply depending on where the clotting occurs or where the hemolysis occurs. You can get decreased blood supply to many of the different organ systems that can lead to necrosis, actually, of those systems. And then of coagulation, of course, if you're talking about coagulation here, you can have small blood clots being formed really anywhere as the red cells open and release. They're going to release plasma coagulation stimulating factors. You can get small clots forming that can lead to DIC, which would be uncontrollable bleeding. So if we look at specifically what happens when hemoglobin spills into the plasma, the damaged red cells are going to release this hemoglobin, it's really a toxic substance, directly into the plasma. But it doesn't stay that way in the plasma. And it's going to immediately, it's going to split once it's released into two halves. They're called dimers, okay? Those dimers are then going to be bound to haptoglobin. Haptoglobin, actually, that's what it does. It's able to bind the dimers. So this haptoglobin hemoglobin complex then goes to the liver, where the liver can process those products. Unfortunately, we have limited amount of haptoglobin in our plasma. So when you exceed that, the haptoglobin stores in the plasma, the free haptoglobin, we start to see hemoglobin building up in the plasma and then spilling out into the urine. That's when you start to see the hemolysis, like in a blood specimen or in the urine. You start to see that hemolyzed blood in the urine. Remember that the kidney can also process hemoglobin. It's not as good at it as the liver. It's kind of a clunky process. And it'll filter that hemoglobin and convert it into hemosiderin. If you see hemoglobin in the urine, it's probably for one of two reasons. Hemoglobin can be released straight into the urine if you have really lots and lots of it. Or what really normally happens is hemoglobin would be absorbed into the proximal kidney epithelium, and actually it'll be basically just deposited there in the epithelium. It'll create little plaques that will actually end up damaging the tissue. So if you have that much, you're not just releasing it into the urine, it is also building up in the tissues of the kidneys, leading to damage within that endothelial tissue. So you can see that you have damage really that can occur across the systems, kidney just happens to be particularly sensitive to it. Now, when we talk about the specific types of reactions, the first one we're going to talk about, and this is not in any particular order, is the febrile non-hemolytic reaction. The ones we were talking about with the intravascular, that's really the immediate hemolytic reaction. But the febrile non-hemolytic reaction, this patient, it might look like that kind of hemolytic transfusion, an acute hemolytic transfusion reaction, but there are other lab results that help you to rule out an acute, an AHTR, okay? And it's important to rule this out during the workup because this is not something we are able to predict. We usually aren't able to predict the fact that the patient has a response against sort of the excess things that are in the component, okay? So you can have, first of all, you can have the donor may have had cytokines, maybe higher levels of cytokines than normal, and those might have been in the component. So when we transfuse the component, there's actually no immune response, but with the component comes all those cytokines that were in the donor, but they're still physiologically active in the recipient. Okay, and so you end up with a fever, but not much else. It doesn't really cause any other issues. Probably the most common issue that we have are the antibodies directed against donor HLA antigens. So even in a red cell product, you're going to have some white cells. So if your patient has antibodies against an HLA type, it doesn't matter which kind, it is much more, we don't HLA type packed red cells. So it is likely that they, could have even a, it's not hemolytic, but it still can be pretty serious. You can have pretty high fever. It's, pretty uncomfortable. It's not usually going to be life-threatening, but if your patient's already sick, why make them more uncomfortable? Especially if it causes like the headache and the pain and the fever and all that stuff. We can avoid that in a patient that we know has been HLA sensitized by adding leukocyte filters or performing leukocyte reduction to our components before giving them. We can also, if we know that a patient has been sensitized against an HLA antigen, we would definitely use some prophylactic anti-inflammatories like acetaminophen, something like that. And you can see here in the chart, that's what we're pointing out here. You're still going to have the fever, you're going to have the headache and the back pain and even the nausea. It's not, your patient's not going to be happy with this. You're still going to have to stop the transfusion because you have to do the investigation. But it's not usually life-threatening. I mean, again, uncomfortable is not, in danger necessarily. And it usually is probably those HLA antibodies. The key things to be in the investigation, what you're going to find is that your DAT is going to be negative and there's not going to be any visible hemolysis in the plasma of your post-transfusion specimen. So you're going to keep giving them anti-inflammatories in order to, stop the response and help them get through it. There are patients who can have allergic reactions to components or to factors within the components that were specific to that particular donor. Sometimes it's any donor would have this, and sometimes it's just a particular, antigen that was in the donor that your recipient, if your recipient is allergic to, I don't know, peanuts, and your donor, I don't know, had peanuts or something like that, it is possible that you could trigger that response in the recipient. So while that one's hard to, you can't really predict that one, some of the allergens do end up in the plasma, and we have to be at least aware of that. Okay, so these allergic reactions can be from something as simple as just a rash, which is urticarial, or all the way to an anaphylactic response. That anything is possible. So, if they have hives, yes, it's uncomfortable, but it's usually not life-threatening. Anaphylaxis is life-threatening, so we generally have to be very aware of patients who are at risk for this. The mild cases, if we know that the patient has had a mild allergic reaction before, we'd probably give them some antihistamines beforehand in order to prevent the symptoms. We can't take into account the allergies that patients have. So for example, I happen to be allergic to ibuprofen. People take ibuprofen all the time. You taking ibuprofen is not going to, prevent you from being a donor. And ibuprofen might be in your system for several days. So maybe you took ibuprofen 2 days ago. If I receive a unit that came from you who took ibuprofen, I probably have my immune response against it. Mine's not serious, so it's not the end of the world. But it is, well, it can be disturbed. I actually just pass out. What might be, I'll be lying in a bed anyway. So, but if your patient has a serious, if I had an anaphylactic response to something like that, like penicillin, what if your donor was taking penicillin? So hopefully the patients who have serious allergies, there are, if we need a particular donut, we could do a directed donation if they have a serious allergy against something common. That is possible. There also are allergies to some of the things that come along with they didn't come from the donor per se. So like allergies against the anticoagulants that there is actually, some patients are sensitive to the citrate that's part of the anticoagulant. And that's something that we can keep track of in a patient's history. And then in that case, if it's the anticoagulant or even if it's an immune thing, we could wash the unit. That's possible. For these patients, for any kind of allergic, you're going to have a negative DAT. This is the key thing here. Negative DAT and no visible hemolysis across the board. The anaphylactic, this is obviously, we know what anaphylaxis looks like. It's very severe, the rapid onset, even a tiny amount of the component has to be transfused and the patient's response will occur. And it can be very severe, difficulty breathing, blockage of the airway, all that stuff. Big difference here, there's usually no fever. So this is a non-febrile non-immune situation. It's non-immune because it's not directed against red cell antibodies. It is immune still, but it's directed against non-red cell issues. Anaphylaxis it is very severe. We're very worried about it. Shock can occur, death can occur, but this one is interesting in that it's usually caused by a deficiency of IgA. Patients who are genetically deficient in IgA frequently have no clinical signs. They don't know their whole life that they don't have any IgA. And IgA levels aren't something we routinely run. So the first time we know about a patient not having IgA, frequently it's when they get a transfusion and then they have an anaphylactic response. So they have so it's usually their second transfusion. They have an anti-IgA. That's an IgG. Okay, so it's an IgG directed against IgA. A little complicated, little too many words there. And what happens is it does result in an anaphylactic response. You get all these, the IgG is pretty good. This particular one actually combined complement. It's kind of just a mess, okay? Again, this would be something in a patient's history if we know about it. No, we can't predict it. But once we do know about it, we can give the patient, obviously we can give them some anti-inflammatories, but the key thing is that we give them IgA deficient units. So we actually have to find other IgA deficient patients and get the units from them, or we just take the units that we have and we give them washed red cell and platelet products to remove the extra plasma that would have the IgA in it. So then we have the last case of immediate immune responses is called trolley. The the TRALI stands for transfusion-related acute lung injury. That's what it stands for. And what we have here, this is something that, again, we can't predict this. It does occur in some patients, and it is very dangerous for the patient. They generally, it would be a second exposure. The patient has been sensitized against some HLA, either class 1 or class 2 factors, and they develop antibodies against those factors. Then when they receive their second unit, those anti-HLA factors will activate neutrophils. The neutrophils then become active, in particular in the lungs, hence the L, and fluid starts to fill the endothelial lining of the lungs. It does happen in other tissues, but the real damage occurs in the lungs, and so you end up with pretty significant pulmonary edema, which is it's basically just fluid in the lungs. Patients drowning from the inside out. Again, this isn't something that we can predict. We don't know that a patient has been sensitized against HLA. However, what we do know is that patients who have more exposure are more likely to develop anti-HLA antibodies. So probably our most common problems with that are multiparous women, so women who've had many children. They're likely to have been exposed to many different types of white cells, and they'll develop, they definitely are foreign to them, they'll probably develop anti-HLA antibodies. So there have been some efforts to try and organize getting plasma products from men, and by giving plasma products that have come from a male donor to multiparous women, we find that we have less incidence of TRALI, which would mean less TRALI fatalities. Unfortunately, the morbidity and mortality rate for TRALI is actually fairly high. You get vascular leakage, so you get fluid leaving. If you look at this cartoon, you start to see increased vascular permeability, fluid leaking, reduction in blood volume and blood pressure, and the biggest problem really is over here with the fluid in the lungs. And then if we go to the immediate non-immune issues, these are things that occur, they're considered immediate, meaning they occur very close to the transfusion, and they unfortunately, they cause their non-immune responses because it's not directed against the red cell. Sepsis is it's an unfortunate factor. You do have to perform phlebotomy in order to gain the units. And so while most bacteria would not survive the storage temperatures that we keep these components at, with the exception of platelets. Platelets have to be tested, though, for bacteria. But your other components don't. So they don't necessarily survive the storage temperatures, but their toxins do. Okay? So if there are toxins in the product, that may occur. We also have to consider those organisms that can survive the lower temperatures. So our most common problems, Pseudomonas is a common problem because, first of all, it's a water, but it grows in the environment, so it can grow at lower temperatures. Yersinia can grow at lower temperatures. And then we have Serratia, Citrobacter, and E. coli. The Pseudomonas, the Yersinia, and the Serratia, they can survive. They actually can do pretty well at those lower temperatures. But the Citrobacter and the E. coli, unfortunately, those guys pretty immune responsive, so we don't really need a lot of them, and they're endotoxins. And enterotoxins can really cause problems with your immune system. So we're talking about organisms that may have actually grown during storage, or just ones that have produced toxins that are now in the bag. So when you transfuse them, you're getting those toxins in the patient. The patient will have a sudden high fever. They'll experience things like abdominal cramps, diarrhea, muscle pain, even shock and DIC, as well as the renal and the vascular collapse can also occur. If we suspect this, then we've got to start intravenous steroids and antibiotics. We've got to compensate for the fluid loss, the volume loss with fluids and electrolytes, as well as vasopressor drugs to stop the shock. Obviously, the best way to prevent this is to be really vigilant with our phlebotomy. Make sure that we follow all the techniques properly and that we're vigilant with our antiseptic techniques. Then we have TACO. TACO, which stands for Transfusion-Associated Circulatory Overload. So the circulatory overload is where basically you're adding too much fluid to this patient. The patient may need the red cells, but they may not have lower volume in their blood. So what can occur if that's suspected is you could do phlebotomy first to remove some maybe some microcytic or some hypochromic red cells and replace those with more normal red cells. What we see, probably the biggest sign we can see is edema. We see, unfortunately, some of it can be pulmonary, and that is an important complication that we have to keep in our eyes. But really, you can see here the edema, seeing it in the ankles, in the eyes, in the face. This is an important thing that the nurses have to look for, nurses and doctors have to look for. Our greatest risk for this is people over 60 and infants. And it really is because of the volumes of components that they receive, okay? It can occur with any volume, but unfortunately, we see this if you do large volume transfusions. The signs of TACO, usually within just a few hours, you're going to start to see difficulty breathing, actually, especially while you're lying flat. Okay, you're going to see cyanosis or blueness around the lips, around the eyes, tachycardia, your heart rate is going to become rapid. You're going to see distension of the jugular vein and something called pedal foot, which is the edema that's shown down in the bottom cartoon, as well as increased blood pressure, dry cough, tightness of the chest, and headache. Now, TACO can be easily confused with trolley because, of course, you can see pulmonary edema with both, and actually you can have both at the same time. So what's the difference between the two? Well, hypertension, TACO always has hypertension, right? Because you have volume, high volume. Trolley, you might have transient hypertension, but usually you end up with hypotension in trolley because remember you have that increased vascular permeability and the fluid is leaving. The fluid is generally leaving the vessels in trolley. In TACO, you've got too much fluid in the vessels, so that's really the issue to differentiate between the two is the hyper versus hypotension. And then, of course, you do have pseudo-hemolytic reactions where you can actually have hemolysis occurring, but it might be from some non-antibody antigen reaction. It could occur for other reasons. So, for example, it could be because of osmotic rupture. If you use the wrong solution during transfusion, so the transfusion usually occurs along with some other fluids. The patient might have hypo or hypertonic solution. If you have the wrong solution, you're only supposed to use physiologic saline when you're doing a transfusion. If they're hanging the wrong bag while transfusing, that can actually cause swelling and rupture of the red cells. So that's something. Make sure that the nurse is hanging the correct bag. That's something we don't control. And the other thing is if you've had damage in the bag, right? So the bag, the bag itself, there's hemolysis in the unit itself, we could potentially be transfusing hemolyzed blood. And of course, the hemolysis occurred in the bag, but you would still get all the same. You're just putting all that stuff right into the patient. There's no haptoglobin in the bag, so it ends up getting dumped into the patient, and unfortunately, you get all the responses. Some of the things that could cause lysis of the red cells in the bag. The biggest thing probably is temperature. So if you have any kind, if you're warming, because we use blood warmers frequently, if that warmer is not working right and it's too high, it can lead to rupture of the red cells. And so that's why we do have to have alarms on all of our temperature sensitive systems. And then of course you do have things like mechanical trauma, like this is still a tissue, be gentle with it. Don't throw the bags around and stuff. So we have to be very careful. We have to use the right size needle so that we don't cause extra pressure. We don't want you to use small bore needles. Don't squeeze the bag. The cells are in there. And then using other things like the different pumps and things that we use. We want to make sure that those mechanical things are all amenable to having red cells pass through them without being lysed. There has been, unfortunately, some association with lysis just because of implanted devices. It could be any kind of device, but foreign devices inside the patient may lead to a small amount of, it's usually not massive, but it might lead to some hemolysis. Okay. One of the things that is a problem with the results from the storage of our components is hyperkalemia. So in the bag, there's still metabolism going on, right? These cells are alive. That's the whole point of them. But as the red cells age in the bag, the potassium levels rise, and you can see a 5 to 6-fold increase in the potassium levels during storage over 3 weeks, because that's about average, about 3 weeks. That free potassium that's now loose in there, you're going to transfuse that into your patient. It can actually lead to significant electrochemical changes that can affect the heart, and we have seen cardiac arrest just from those potassium levels. If a patient certain patients are at risk for that. The ones who are at risk for that are patients who have renal impairment that can't eliminate that potassium, neonates who by definition have their renal function isn't really up to snuff yet. They're just born, busy getting born. And those who receive massive transfusions, so they're receiving a lot of that potassium. So what we have to do, if we know that these patients are at risk, is we're going to administer things like calcium glutamate or calcium chloride or some other kind of cation exchange resin during the transfusion in order to mitigate that large potassium volume that they could, or larger potassium volume that they could be receiving. And then of course we do also have to worry about temperature. If we give the patient, we're not giving them cold, right? We don't give them chilled blood. The units are routinely given to the patients at room temperature. But the patient is not room temperature, hopefully, for a long while. The patient is 37. So when we give large numbers of units, so for massive transfusions, we can actually drop the patient's temperature, their body temperature, by giving them, a large number of these relatively cold units. And so we've seen patient temperatures drop from 37 to 27, even from 27 to 29 degrees. Well, that's hypothermia. So we have to worry about that. Hypothermia has risks of cardiac reactions. You have ventricular arrhythmias, even cardiac arrest that could occur. And so we know that this is a risk with large transfusion volumes, so massive transfusions. So if you are doing large volume transfusions, using a warmer will prevent that. Okay. There are patient conditions that can also cause specific reactions. So there are certain patient situations where we would look for these non-immune but immediate reactions that occur. The patients who are highest risk of these, patients with the G6PD deficiency, patients who have a Clostridium infection, patients who have nocturnal PNH or paroxysmal nocturnal hemoglobinuria, patients with sickle cell disease, patients with hemolytic uremic syndrome, and patients with thermal burns or hematomas. Also, patients where we've seen our red cell sequestration, or if they already have gone through autoimmune hemolytic anemia, they're at higher risk for these pseudohemolytic reactions. And so we need to be aware of these and have that complete history on the patient so that you can be extra vigilant and incorporate things like these, you know, the cation exchange reactions, making sure that the right bags are hung, and use a warmer. Okay, the delayed reactions. So the delayed reactions, a little bit different. These, we said they can occur more than 24 hours. That's definitely true. I think most books tell you 3 to 7 days. It usually is a few days following the transfusions. That'll be our average, okay? It does have to occur more than 24 hours after, but our average will be 3 to 7 days. And these are usually, they're most often a secondary response, meaning that the antibodies were weakly responsive or anamnestic, where the patient's been sensitized in the past, you know, transfusion or pregnancy, but we didn't detect the antibody on screening. So these ones, we didn't really know that the patient had this because it was such a weak antibody titer. Probably the most famous one that can do that is the JKA. Anti-JKA is famous for being weak, weak enough that we don't detect it on an antibody screen, and so then you do see a delayed reaction in the patient after the transfusion component is given. We also can see this with several other families. You can see here KID, Duffy, Kell, and the MNS families, but that's why a complete history is important. Okay. The patient will have some hemolysis, and you'll see a decrease in the hemoglobin and the hematocrit levels, but it's generally extravascular, and so you don't see that massive, the severe, you know, problems that the patient has, you know, shock and all that stuff. But you would see, if you did some lab results, you know, the doctor would have given the blood transfusion, but wouldn't see the clinical improvement that he or she expected. So then you do secondary labs, and you're like, wow, their hemoglobin actually dropped. Wow. You know, their hematocrit is actually lower. And then you start to do a research, you know, so an investigation into it, and you find the patient actually has an antibody. Anti-KID, JKA, anti-E, anti-D, anti-C, anti-Kell. These have all been implicated. Duffy A, M, they've all been implicated in that. Now the E, the D, and the big C, those are less, you know, they're more likely to give you a severe one, but they can do the extracellular. It is possible. So basically what's happening is the antibody, which is generally IgG, will bind to the red cell, but it won't trigger a complement cascade. Instead, it'll be sequestered in, say, the spleen or the liver, and it'll be removed by the reticuloendothelial system. Since there's no lysis of the red cell in the blood vessels, there's no release of free hemoglobin, so there's no damage. Generally we don't need to treat this. We just need to keep track of the fact that there's actually an antibody there. Okay. The patient actually might feel uncomfortable. They might feel poorly, is the way they usually describe it. And usually it'll be a couple, week or 2 weeks after because you see an antibody, it'll follow the antibody response. So it'll occur a week or 2 after the transfusion. They didn't feel very well, and their urine might get darker because there might be some hemoglobin, maybe even some bilirubin in their urine. It came from the liver, though. We're not sure. It didn't come from. It's not free in the urine. The key thing with this is the patient actually didn't gain anything from the transfusion. So they went through that risk of exposure to a donor, but they didn't gain anything from it. Extravascular hemolysis. In this case, we know that the hemoglobin can still be recycled. Everything's going to be recycled. So the globin chains are going to be broken down into amino acids, and those actually will be returned to the plasma pool. Nothing particularly fancy about that. The iron is going to be recycled. You're going to use that again. And the heme portion is going to be converted in the recycle process into porphyrin, which will be carried to the liver by albumin. Okay. And it'll actually be through the process. It'll be as bilirubin, in the liver, and the liver will process that bilirubin from unconjugated to conjugated. It'll enter the intestine through the bile duct, and isn't that fun? And it'll leave the system. Certain amount of urobilinogen will be reabsorbed into the blood by the intestines, and then that will be excreted by the kidneys. So you remember this cycle. It's very exciting for you, I'm sure, to revisit it again. Just remember that this cycle is still there. So depending on how much extravascular hemolysis you have, you might see, and how healthy the patient's liver is. Okay, because we don't really know that, right? Patient who doesn't have a healthy liver, you might see some backup of the bilirubin, or even, unfortunately, if they're not producing albumin, you might see, hemoglobin, porphyrins, those kind of things building up. Depends on the liver, how healthy it is. That can back up into the plasma, and then even be dumped out into the urine. It's all possible. So once that unconjugated bilirubin is carried to the liver, just to talk about what goes on in the liver, it's going to, be combined with glucuronic acid, and that's your conjugated. So it starts out unconjugated, you add glucuronic acid, and you get conjugated bilirubin. Most of that is going to go through the bile ducts into the small intestine, where it's going to be converted into, you go through the stercobilinogen to the urobilinogen, right? And we like our bacteria in our intestines. They're big helpers with that, okay? The stercobilinogen is going to be excreted, into the stool. The intestines are going to reabsorb a small amount of the urobilinogen, and then that's going to be filtered out through the kidneys. Okay, again, it's not really all that exciting, but it is. You need to know all of the players. Okay, you need to know all the names, because somebody might ask you about them. Okay, then we have our HLA people. So HLA antibodies, these are the most common place we see them are with multiparous women. Multiple pregnancies, the mother interacts with cells from the infant and produces antibodies against them. Because there's still going to be some white cells or platelets in any component that we give, they could develop an antibody response against that. Remember, there's no HLA on the red cells, but platelets and antibodies do have them. And so we can see those HLA antibodies triggered in certain patients. Again, we talked about this before. We try to give the patient, if we give the patient male blood, male components, they're much less likely to have this reaction. And so if we start to keep track of that, it can help potentially our patients who receive these units. This is not anything new here. You can see we can in transplant issues, we're obviously very sensitive to HLA deficiencies, and we know that the rejection that occurs because the HLA is expressed by all kinds of body tissues, it can be directed against any part that's received. In this cartoon here, what you're seeing is actually a kidney rejection. But when we're talking about a blood component, they're rejecting the cells, the white cells that were in the unit that you gave them. It's usually not as obviously severe as losing a whole kidney, but it could still be anaphylactic, and that can lead to shock. So we do have to worry about this. The first thing is seeing about instituting, it's not a requirement yet, there's still studies going on. Is it worth instituting the policy of giving male units to multiparous women? They've seen some success with that. And then we have transfusion-associated graft versus host disease. This is, we definitely have to know about this. This is very rare, but unfortunately, it is highly lethal. It's associated with a 90% fatality rate when it occurs. In this case, remember, we said that this is a delayed response. We said that any patient, any component that we give, is going to have some white cells from the patient, from the donor. Well, those white cells are active. And one of the things, while the red cells are going to last about 120 days and then be recycled by the host because they don't divide on their own, the white cells are capable of clonal expansion. They're capable of dividing. So just like the recipient might have a white cell that can respond against HLA that's expressed by the donor, so the white cells in the component might respond against HLA in the recipient. That's a problem. Okay? Now normally, in this case here, normally if you get it looks like Pac-Man here, but if you get a white cell responding against the HLA, as you see here, we do have immune suppressive cells that are able to detect that and cancel it out. Well, that's lovely. Unfortunately, in patients who experience transfusion-associated graft versus host, they're usually missing that suppressive cell. Okay, there are reasons why they have that. Either they're immunocompromised, or in some cases there are, like if they have sepsis, you can see this more commonly. If there's no counterattack, if there's no suppressive cell, those cells will undergo clonal expansion, and they'll keep attacking the HLA, which is expressed where? Everywhere. And so all of these cells will attack the patient's own tissues, all of them. Okay, so it's the donor lymphocytes that are the problem. There's no treatment for this. Once we know that this is happening, it's 90% fatal. Okay, we don't have a treatment for this at this point, not an approved treatment. Okay, so we need to try and prevent this. So what we do is we irradiate the blood product. It doesn't really do much to the red cell, but it will deactivate the lymphocytes. And so that while they can still interact with your HLA on that tissue, they can't go through clonal expansion with the radiation. Okay, that's the key thing. There's no clonal expansion with the radiation. So these tissues might, a small amount of tissues might be at risk, but you won't get every tissue being at risk. Okay, this is again another unlikely, rare situation that can occur. It usually occurs in patients 5 to 12 days post-transfusion, so it's delayed. And what happens is after the transfusion in those 5 to 12 days, all of a sudden the patient's platelet count drops through the floor, and they have all of these purpura and bleeding episodes, which you can see here in the picture. Okay, this is actually usually an anamnestic response, so a memory response that already exists, and it's likely associated with a platelet antigen. It's a high incidence platelet antigen called HPA-1A. Most of the population expresses that. About 98% of the population expresses HPA-1A on their platelets. So only patients who are HPA-1A negative, only 2% of the patients, they could become sensitized to that antigen. And unfortunately, they'll develop an immune response against it. And unfortunately, they're the ones who are at risk for this. Even though it's directed against HPA-1A, which is expressed on the donor platelets, for whatever reason, this antibody also destroys the recipient platelets, their own platelets, which is why their platelet number, whether they didn't necessarily get platelets, but their own platelet number drops through the floor. They lose literally all their platelets. Both the donor and the recipient platelets are destroyed. So you get all these hemorrhages. Obviously, our biggest concern is a hemorrhage in the brain. That would be our major concern, and it can happen. So if we see this in the patient, actually what we're going to try and do is try and remove those antibodies. And the way to do that is plasmapheresis or exchange transfusion, where we're actually giving the patient, we're replacing their own plasma with plasma that doesn't have their antibodies, and then we use corticosteroids. How do we prevent this in the future? You have to give washed units. You can't give platelets, obviously, but you have to give washed units so that they don't have the platelets, those few platelets in them. There's a few other delayed non-immune things that can occur. So these are things, they're non-immune, so they're not things we can predict, or we have a hard time, we don't predict them with our testing. But they are, secondary to receiving usually more than one transfusion. And one of them is hemosiderosis. It's basically excess iron, right? So you've given more than one transfusion, and usually we recycle iron in the blood. So if you're giving those extra blood cells, you're also giving extra iron, and the patient still absorbs iron normally in the gut and all that stuff. So they might not have had a loss of iron, but you end up with all this excess iron that'll accumulate in the macrophages and in the tissues. Generally, the places where we see this are in patients who have to have regular transfusions, like over their lifetime. So this is patients who have things like thalassemia or sickle cell. And so they end up really getting about an extra 250 milligrams of iron every time they receive a unit. And we don't excrete that much iron. We only excrete about 1 milligram of iron a day in our, usually in our stool. So if you're receiving 250 milligrams, let's say you need a transfusion, you have thalassemia, and you receive a transfusion every, I don't know, month or so. Well, you're going to have iron overload, okay? And those iron deposits are going to occur. They can occur anywhere, liver, kidney, heart, okay? But they interfere with the function of those units. So one of the things that we can give you are chelators. Chelators will bind to the excess oxygen, to the excess iron, and that'll allow it to be removed either through the urine or the stool. And these usually will be part of these patients' regular treatment. So with the transfusion, they'll also receive a dose of chelators. And the chelators, the most common ones that are used are defriprone or deferoxamine. Those are the common chelators that bind iron. Then we also have citrate toxicity. Citrate is part of the anticoagulant that's in the unit, 63 milligrams usually, milliliters, sorry. So for patients who receive multiple transfusions, they can, it has nothing to do with it, it's non-immune, right? You're not allergic to the citrate. But the citrate in larger volumes, as you receive more and more, is toxic. So those patients who receive larger volume or larger numbers of transfusions, you can see liver impairment due to that citrate toxicity. The liver just can't keep up. So unfortunately what happens is the citrate can actually bind to the calcium that's in your blood, removing it physiologically from it can't do its job now. Without the calcium, the patient usually experiences things like muscle tremors, but unfortunately that can include the cardiac muscle, and so you can get cardiac arrhythmias. You can get like tingling sensations. Very common to have a tingling sensation around the mouth as your calcium is lowered because of citrate toxicity. So what do? We actually add calcium glutamate or calcium chloride. You don't do it at the same site as the infusion. You do it at a site away from the infusion, and that should stop the symptoms. But in order to prevent the citrate toxicity, you really should give washed units to remove the anticoagulant. So in larger volume or larger numbered transfusions, you would start washing the units for several reasons. This is one of them. So, okay, so what actually happens? A transfusion reaction investigation, what are the steps that actually happen? Well, it actually starts with the clinical staff, right? The nurse or the physician. They're going to stop the transfusion, okay? And they're going to keep the line open with saline because we want to see maybe we don't have to completely abandon this unit, but we have to stop it. So you're going to stop the unit, and then you're going to keep the IV line open with saline. And the first thing that you're going to do is perform a clerical check for ID errors. Okay, so this is all the stuff that the clinical staff is doing. They have to contact the treating physician and monitor, obviously, the patient vitals. Make sure you're watching the temperature, blood pressure, pulse, all that stuff. We also want them to collect samples. Obviously not from the same exact site, but we want post-transfusion samples, and you're going to return that with the bag and the attached IV fluids to the laboratory. So the laboratory is going to receive all that stuff, and they're going to start their part of the transfusion reaction. And our first steps, obviously, a clerical check. Is the ID correct? Did we do this correctly? Then a visual check. Do I see hemolysis, or is it icteric? Do you see a buildup of you see these specimens here, you have actual hemolysis. And the second specimen here, in this one, it's starting to turn gold. That might be bilirubin, okay? And then we're going to perform a DAT. We want to actually see if we have sensitized cells in this specimen. If we suspect that there has been an antibody response, you can see the tests that we're going to run. Again, the clerical check, most important thing, we always have to do that. Here's our visual test for hemolysis or buildup of bilirubin from cell lysis, and our DAT. The DAT, if it's positive, tells us that there is an alloantibody. We missed it. and we got to find out, now we have to really work it up and find out what that antibody is reacting with, okay? We still perform A, B, O, and D phenotyping on both the patient and the donor, just to see again if was there a clerical error and that was noted wrong. We also do an antibody screen. Maybe we missed an alloantibody. We're going to do it pre and post, okay? Maybe we missed it. And we're going to repeat that cross match between our donor and our patient to see maybe we misread that cross match. Some of the other lab results that we would be interested in, hemoglobin or hematocrit, has there been a reduction in that? Is it physiologically effective? Is there a reduction in the haptoglobin levels? Is there an increase in the bilirubin levels? Is there urine hemoglobin? That would be a sign of hemolysis. Then we actually also have to inspect the donor unit. We want to see if there's any hemolysis present in the unit itself or if there's bacterial contamination. We could do a gram stain and a blood culture to check for that. This is just, you can see here a chart to help sort of narrow it down, okay, to give you the causes, the signs and symptoms, and the clinical tests that would tell us if that was the cause. Okay, so this is, I'm not going to read it to you. You can read it yourself and you can see. Here it is. All the stuff you need, everything you ever wanted to know about an adverse complication or a transfusion reaction.